Good morning. My name is Dr. Vidya Prakash. I'm a professor of internal medicine and infectious diseases at Southern Illinois University School of Medicine. And I also have the honor and privilege of being president of SIU School of Medicine's Health for the World Infectious Diseases chapter. Welcome to Health for the World Grand Rounds. It is truly an honor to present my colleague, Dr. Zainab Alnafoosi, who is an infectious diseases faculty and assistant professor of clinical internal medicine at Southern Illinois University School of Medicine. Dr. Alnafoosi is a treasured member of our division and a gifted educator, very devoted, dedicated, and gifted educator. And so it really will be a treat to hear from her today as she talks about aspergillosis. So without further ado, Dr. Alnafoosi, and many thanks to the Health for the World team and leadership for this opportunity.
Thank you very much, Dr. Prakash, and thanks for the nice introduction. My name is Dr. Alnafoosi, and I'm honored to be here with you today. I thank the organizers on Health for the World, and I thank the audience for joining us today. Let's start with our talk. I'm going to talk today about aspergillosis, a specific kind of fungal infection. So let's start. Aspergillosis is a collective term used to describe all disease entities caused by any one of the 35 pathogenic and allergenic species of Aspergillus. Aspergillus is a mold with hyaline hyphae. Only those that grow at 37 degrees Celsius can cause invasive infections. However, even those without this capability can cause allergenic manifestations. As we all know, invasive aspergillosis is a major cause of morbidity and mortality in immunocompromised patients. And we'll start a little bit with epidemiology. So Aspergillus is a ubiquitous group of molds. They are found everywhere worldwide. They are most commonly there in the decomposing plant materials, hay, soil, basement, heating, ventilation, and AC systems, as well as plants. Aspergilli are there indoor, they are outdoor, they are on surfaces, they are in water. So they are basically everywhere. The high efficiency particulate air filtration or HEPA filtration is often protective against infection from this fungi. And thus it's recommended to use HEPA filtration systems in hospitals, in hospital areas that host patients that are high risk. Outbreaks usually, in hospital outbreaks usually are related to contaminated air source in the hospital. So Aspergillus is branching molds that produce vast numbers of small conidia or spores that can be inhaled. And the required dose of the infecting inoculum is uncertain, but it usually requires an intense exposure with the big load for us to cause a disease in a healthy immunocompetent individual. And hosts with normal pulmonary defense rarely develop disease despite exposure. However, allergic syndromes may be exacerbated by continuous antigenic exposure from sinus or from airway colonization. And the incubation period of invasive aspergillosis is actually variable. It can be as short as 2 days or as long as 90 days, so 3 months. And we come to talk about risk factors for aspergillosis. The main 2 risk factors are profound neutropenia and prolonged corticosteroid use. So the longer the duration of neutropenia and corticosteroid use, the more the risk of getting this invasive aspergillosis, and actually the more the mortality as well. Second, a neutrophil or phagocyte dysfunction. like what happens in chronic granulomatous disease or advanced HIV or relapsed leukemia. Other immunocompromised hosts, especially solid organ transplant recipients, including lung transplant, heart transplant, and liver transplant. Patients on biologic therapies, and also patients with acute illnesses like COVID or patients in the ICU. This by itself can be a risk factor. So for patients with chronic pulmonary aspergillosis, which is a different entity than invasive aspergillosis, these usually have underlying pulmonary disease or like structural lung disease like COPD, bronchiectasis, sarcoid, TB, and others. And on a more sophisticated level, a genetic defect in mannose binding protein or cytokine regulation could cause inability to mount an inflammatory immune response or T helper 1-like response. Allergic bronchopulmonary aspergillosis has been found to be associated with certain HLA class 2 types, like polymorphism of interleukin-4, interleukin-10, and SPA2 genes, as well as heterozygosity of CFTR gene. And there seemed to be association between genetic association between that leads to development of an allergic response to Aspergillus fumigatus, and this is what causes, or they think that causes ABPA or allergic bronchopulmonary aspergillosis, and we're going to come into that. It's also thought that this response can be actually protective at times from invasive disease, because these patients with ABPA, despite being on high dose of corticosteroids, they rarely, if ever, develop invasive aspergillosis. And we can see here a graph showing the degree of immunocompromise status, and then the correlated risk of acquisition of aspergillosis. So as you see on the right side over here, the highest risk are for patients with leukemia with a relapse or uncontrolled allogeneic stem cell transplant plus GVHD, patients with profound neutropenia, patients with solid organ transplant with rejection or CMV, patients in medical ICU with COPD, sepsis, AIDS patients, long-term glucocorticoids, temporary neutropenia, and then lower and lower risk like chronic leukemia, HIV infection, acute respiratory infection like influenza or COVID, and so on. And this is a table that shows the incidence and mortality of invasive aspergillosis in transplant recipients. So we see over here that the incidence of 7%, the highest incidence of invasive aspergillosis happens in allogeneic stem cell transplant recipients, and with high mortality that reaches 40 to 75%. The next people on risk are the lung transplant recipients, and then liver transplant recipients, and then heart transplant recipients at 2%. We'll come to talk a little bit about microbiology of Aspergillus. So Aspergillus species grow in vegetative state. They are composed of hyphae, which are long, tubular, hyaline in color, meaning not black. They are 2 to 4 micron wide. They are usually septate, as you see in this illustrative picture, and they branch at acute angles. And then, so we have here the hyphae, we have the conidiophore, and then we have the small conidia over here. These small spherical structures, 2 to 5 microns in size, they are the ones that gets inhaled. They are usually hardy, and they go and settle into the lower respiratory tract or into the sinuses. And we have here the growth of Aspergillus fumigatus on a potato flakes agar, and under a microscope photo for Aspergillus fumigatus, like you see over here, small conidia and the conidiophore. So Aspergillus was named after aspergillum, which is the tool that is used to sprinkle holy water, because it looks like it. So the most common species that cause human disease are first the Aspergillus fumigatus. It's responsible for most cases of invasive aspergillosis, around 90%. almost all cases of chronic aspergillosis and most allergic syndromes. Next one is Aspergillus flavus, which can cause sinus infections, cutaneous infection, as well as keratitis. The third most common one is Aspergillus tertius, and usually this one is associated with invasive disease, poor prognosis, and resistance to amphotericin B. Aspergillus niger causes colonization, sometimes invasive infections, and it also causes external otitis. So the usual route for infection, like we said, is inhalation of the conidia into the lungs or sinuses. However, there is the other less common route of infection is like local tissue invasion in patients who have surgical wounds or trauma wounds or burns or contaminated IV catheters, especially in immunocompromised patients. The first line of defense in our respiratory system is ciliary clearance. And then once these conidia reach into the alveoli, the pulmonary macrophages become the major line of defense. And after the cells germinate, the PMLs come to act and kill both swollen conidia and hyphae. And this may be enhanced by the opsonization from the complement and mannose binding protein pathway. So this is how our immunity tries to come and defend the body against the infection from Aspergillus. After pulmonary exposure and in the absence of sufficient pulmonary defense, the inhaled small conidia enlarge and germinate, like you see in this diagram, and then they start to form hyphae, and then they cause a subsequent tissue and vascular invasion. They reach to the vessels, and eventually they may lead to dissemination. So the cardinal or hallmark feature of invasive aspergillosis is vascular invasion and pulmonary infarction. And here's a nice electron microscope a picture of how the macrophages here engulfed the conidia, the first picture, and then the second one they are germinating, but then they show you a comparison between an immunocompetent macrophage that caused the death of the conidia that were ingested and formed this crescent shape structure, compared to the right side when the germination of the conidia inside the macrophages continued to happen because it was an immunocompromised macrophages, and then it led to the death of the macrophage eventually in the continuous germination of the conidia. And here's the gross specimen on the right of a lung, infarcted lung, like you see, it's black in color. This has happened due to, from infection due to Aspergillus MG invasion on gross lung exam over here. The image on the left shows lung tissue section showing acutely branching septated hyphae that are invading the vessels, and that's the cardinal feature as well for the invasive aspergillosis. It invades the blood vessel, so it's angioinvasive. And here we're going to talk more about clinical related things. So aspergillosis causes variety of syndromes that vary with degree of immune response. So it's not one disease, it's actually a spectrum of diseases or syndromes. If we have hypersensitive or a high immune response, we will the host will likely get hypersensitivity manifestations or allergy manifestations, especially if the host has asthma or cystic fibrosis or abnormal lung to start with. So with intact immune response, they're likely to get allergic bronchopulmonary aspergillosis or severe asthma with fungal sensitization. However, if we have more complicated structural lung disease like COPD, emphysema, bronchiectasis, And a patient who's not very immune compromised, he has some degree of immunity. And so these patients that may develop they develop chronic entities or chronic infections from aspergillosis, like aspergilloma or chronic pulmonary aspergillosis, or semi-invasive or subacute invasive forms. As opposed to patients who are severely immunodeficient, as we said, patients who have hematologic malignancies or prolonged neutropenias, they have no immune defense. So the disease here is more invasive, it's more rapidly progressive, like invasive pulmonary aspergillosis, bronchial aspergillosis, or disseminated or extrapulmonary disease, including CNS. And here's a table that classifies the major manifestations of Aspergillus disease according to the organs. As you see on the left, lung, sinus, brain, skin, heart, eye, and as well as the invasiveness or chronicity of the disease. So we have the invasive ones like invasive pulmonary infection, invasive sinus infection, CNS abscesses or CNS infections, as well as disseminated like endocarditis, endophthalmitis. And then we have the chronic manifestations like chronic sinusitis, chronic pulmonary aspergillosis, and so on and so forth. As for the saprophytic, it means like more of fungus bowl. So think about fungus bowl in the lung or fungus bowl in the sinuses. And then we come to allergic manifestations, as we said, like the allergic bronchopulmonary aspergillosis or allergic sinusitis or severe asthma with fungal sensitization. So I would like first to start talking about invasive aspergillosis. It's 80% of invasive aspergillosis is actually pulmonary manifestations, so lung manifestations, and the frequency of invasive disease and the pace of its progression increase with the greater degree of immunocompromise. Patients with IPA would come with fever, cough, chest discomfort, hemoptysis, and shortness of breath. However, some of them may be asymptomatic, especially if they are severely immunocompromised and neutropenic. The key to early diagnosis and at-risk patients is keeping high index of suspicion, as well as screening for circulating antigen and urgent CT chest. We're going to come later into details about how to diagnose invasive pulmonary aspergillosis. So it's arbitrarily divided into acute and subacute forms. The acute form usually happens in less than 1 month time, and it happens in patients who have severe immunodeficiency, like acute leukemia, aplastic anemia, allogeneic HSCT recipients, AIDS patients with CD4 less than 100, and so on. As for the subacute infection, it's more cavitary and necrotizing. So as the name implies, it's less rapidly progressive than the acute form. It happens in the time frame of 1 to 3 months, and typically happens in patients who have structural lung disease to start with, like emphysema, sarcoid, bronchiectasis, and so on. As for the radiologic finding for the IPA, I can find solitary or multiple pulmonary nodules, peripheral wedge-like areas of consolidation that represent hemorrhagic pulmonary infarcts. In very rare and advanced cases, you can find adjacent chest wall invasion or mediastinal structure invasion. And as we see on this CT sections on the right side, this is the classical halo sign that usually indicates aspergillosis, but if it's not there, it doesn't rule out aspergillosis. So you see a dense area of round consolidation, and then surrounded by low attenuation of ground glass opacification, and that basically shows that the hemorrhage that has happened around the area of necrosis. And as the time passed by, and even if the patient is already on treatment, the necrotic area of the lung kind of separates from the surrounding parenchyma and causes this, what we call as air crescent sign on the right side. This is usually later. However, the halo sign in panel A usually happens earlier in the disease. On the left is just the chest X-ray that shows diffuse pulmonary infiltrates bilaterally in invasive pulmonary aspergillosis. The next entity is a tracheobronchial aspergillosis. And this happens with when the aspergillus invade the mucosa of large airways and could cause thick adherent plaques and cause endobronchial narrowing, mucosal ulceration, or even sometimes perforation. Pseudomembrane happen, and this could cause life-threatening airway obstruction as well as respiratory failure. And patients at risk are hematologic malignancy, HIV, and also lung transplant patients, especially at the area at the anastomosis. Symptoms: dyspnea, cough, wheezing, and lobar atelectasis on imaging. Diagnosis usually by bronchoscopy, biopsy, and culture, and it requires to initiate antifungal therapy as soon as possible, plus minus bronchoscopy intervention if needed to open the airway. Next invasive aspergillosis entity is invasive sinusitis, and it could happen up to 5 to 10% of patients with invasive aspergillosis. Patients come in with fever, nasal orofacial discomfort, blocked nose, and nasal discharge. And you can see necrotic looking tissue on rhinoscope examination. We do CT or MRI of the sinuses, but that doesn't really distinguish it from other causes of sinusitis. So you should just keep high index of suspicion in the correct patient. As for disseminated aspergillosis, aspergillus can disseminate from the lungs to multiple organs, basically brain, skin, thyroid, bone, kidney, liver, GI, eye, heart valves, CNS shunts, catheters. It could reach anywhere. The most common features are gradual clinical deterioration over 1 to 3 days, and that is usually rapid, with low-grade fever and features of mild sepsis and multiple non-specific abnormalities on the lab test. In most cases, at least one localization becomes apparent, but keep in mind that blood cultures are almost always negative when it comes to disseminated aspergillosis. Actually, most of the blood cultures that turns to be positive for aspergillus, they are lab contamination. And disseminated aspergillosis sometimes can manifest in the skin, causing cutaneous manifestations, erythema or purplish areas that necrotic areas that turns into a scar. And so when you see that, think about dissemination and look for a primary focus of infection. In the right setting, I mean, patients who are neutropenic or burn patients severe trauma patients, they can have local invasion of the skin, especially at the site of IV catheters. But otherwise, think about cutaneous aspergillosis as a manifestation of dissemination. Next invasive syndrome is cerebral aspergillosis. When hematogenous dissemination happens and goes to the brain, as you see on the right side CT scan image over here. It's a large brain abscess with ring enhancement and extensive edema around it. This is actually a devastating complication, and it's the poorest prognosis of all of the invasive aspergillosis syndromes. This would cause hemorrhagic infarction typically. Less common manifestations would include meningitis, mycotic aneurysms, and cerebral granulomas. And MRI is the most useful immediate investigation, but it's also not confirmatory. You know, histopathologic is the best way to confirm the diagnosis. Aspergillus endocarditis, it's a rare entity, but it's been reported. It typically happens with a prosthetic valve, and it's a result of contamination during the surgery. But native valve diseases also have been reported, especially in patients who inject IV drugs. A lot of times they present as culture negative endocarditis with large vegetations, and blood culture is also usually negative in Aspergillus endocarditis, usually in blood to provide the diagnosis. And now we'll come to talk about chronic or saprophytic aspergillosis syndromes, which is much more insidious than invasive syndromes. We'll start with chronic pulmonary aspergillosis, and that by itself is not it's not one disease. It's rather a spectrum of disease, and so you can think about it as different entities with some overlap. It could, we have Aspergillus nodule, can be just nodules, and then we could have Aspergilloma that could be single or multiple, complex. Then we have chronic cavitary pulmonary aspergillosis, where we have multiple cavities and they're there for a prolonged period of time. And if that is not treated, usually it progresses to chronic fibrosing pulmonary aspergillosis. Between the chronic and the acute comes the subacute invasive aspergillosis or chronic necrotizing pulmonary aspergillosis. So it's not exactly chronic, but it's less rapid than the acute. It's called subacute, and it's generally put under the chronic pulmonary aspergillosis title. All of these syndromes typically happen in patients who have some degree of immunity, so they are usually not immunocompromised. However, they have structural lung disease. Since they are chronic entities, Aspergillus antibodies will be usually positive in the blood. So we start with the Aspergilloma or fungus ball, which is a solid mass of hyphae growing in a pre-existing pulmonary cavity. This cavity could have happened from emphysema, sarcoid, previous lung abscess, congenital cyst, histoplasmosis, tuberculosis, anything. It could be solitary, or it could occur in the context of chronic pulmonary aspergillosis. Most of the time it's asymptomatic. Some people have minor symptoms like cough, wheezing, and fatigue, but it sometimes could cause life-threatening hemoptysis. As you see on this CT scan, the diagnosis of Aspergilloma is with radiologic evidence of a round mass in a pulmonary cavity, plus microbiologic evidence of Aspergillus, whether that is a culture from sputum or a detectable Aspergillus IgG in the blood. And if it's a single cavity and stable over 3 to 6 months and in non-immunocompromised patients who has minor to no manifestations, and you can call it a simple Aspergilloma, that doesn't necessarily need treatment. The next entity under the CPA is Aspergillus nodules. As you can see in this picture, is irregular, irregular borders nodules. It's an unusual form of CPA, chronic pulmonary aspergillosis. These may start like that. It's usually there is no invasion on tissue biopsy, although there may be some necrosis, but typically there is no NG invasion over here. These may or may not cavitate. They usually happen in immunocompetent patients. And on the scan, they may look like tuberculoma or lung cancer or cocci. So histology is usually provides definitive diagnosis. The next entity is chronic cavitary pulmonary aspergillosis, which is the most common form of CPA. You have multiple cavities, which may or may not contain Aspergilloma, in association with pulmonary and systemic symptoms, as well as high inflammatory markers. Actually, some people have more systemic symptoms than pulmonary symptoms. It usually happen in insidious onset, typically more than 3 months. If it's untreated over years, this cavity may enlarge and form pericavitary infiltrates or even perforate the pleura. And serologic or microbiologic evidence of Aspergillus is usually required for diagnosis. As you see on this CT scan on the left, on your left hand, there are multiple thick and thin walled cavities. One of them on the right down here contains Aspergilloma, and you can also see pleural thickening. The next entity is semi-invasive or subacute invasive aspergillosis or chronic necrotizing pulmonary aspergillosis. It's like we said, it's on the spectrum between invasive pulmonary aspergillosis and chronic pulmonary aspergillosis. It happens in patients who are mildly immunocompromised or debilitated patients like diabetes, HIV, malnutrition, advanced age, alcoholics, patients with non-tuberculous mycobacteria, and chronic steroid users. It has similar clinical and radiologic features to CPA, but it's more rapid in progression. So it typically takes 1 to 3 months. And patients, they usually have detectable Aspergillus antigen in blood as well as parenchymal invasion on biopsy, because, and as we said, this is a semi-invasive or subacute invasive. So there's some degree of tissue invasion over here. And as you see on this CT scan, you can see 2 thick wall cavities over here, surrounded by almost normal lung tissue. And then we have the chronic fibrosing pulmonary aspergillosis, which is usually the end stage of untreated chronic cavitary pulmonary aspergillosis. Extensive fibrosis happen with fibrotic destruction of at least 2 lobes, leading to major loss of the lung function. And as you see on the CT scan over here, there is atelectasis and fibrosis of almost the entire left lung. Now we come to chronic sinusitis that could happen secondary to aspergillosis. They are also different entities. It could be sinus aspergilloma. Just think about it as a fungus ball in the sinus, typically the maxillary sinus, and there is no tissue invasion. This is usually associated with prior upper jaw root canal or chronic bacterial sinusitis. Surgical removal of the fungus ball is what is required to treat this. And then we come into the chronic invasive sinusitis. It's invasive, but it's chronic, so it's a slowly destructive process. Happens usually in the ethmoid or sphenoid sinuses. Patient is usually immunocompromised. You can get on the scan, you'll see a pacification of sinuses, local bone destruction, and invasion of local structure, symptoms, headache, anosmia, or symptoms related to involvement of critical structures like proptosis, for example, or facial swelling. And in the histopathology, you will see tissue necrosis and invasion. The other entity is chronic granulomatous sinusitis. It's most commonly seen in India and Middle East. It's caused by Aspergillus flavus, and it typically presents late with facial swelling and unilateral proptosis. And on the histopathology, you see granulomatous reaction, and that's different than the other invasive sinusitis. So that was all for the chronic or saprophytic aspergillosis syndromes. We come here to talk a little bit about aspergillosis allergic syndromes. So it's more of allergic manifestations of people who have a higher degree of immunity. Allergic bronchopulmonary aspergillosis, it's a hypersensitivity reaction in predisposed individuals to Aspergillus fumigatus. Although some rare cases could happen due to other aspergilli or fungi. It happens in 1% of asthma patients and up to 15% of patients with cystic fibrosis. It presents with shortness of breath, cough fits, and bronchial obstruction with mucus plugging, with thick sputum, usually brown in color. Eosinophilia commonly develops before systemic glucocorticoids are given. And the typical radiologic findings is fleeting chest infiltrates, meaning they change the location. It's elected to plug segments due to mucus plugging and causes air trapping. Typically, you could see central bronchiectasis, but also at times peripheral bronchiectasis could be there. And this is a diagnostic criteria for ABPA developed by the International Society for Human and Medical and Animal Mycology. So patients should have one of the predisposing conditions, whether it's asthma or cystic fibrosis. And obligatory criteria, both must be present, either serum IgE level against A. fumigatus that is positive or as positive Aspergillus skin test, plus having a total IgE level more than 1,000. And on the right, you have to have two out of these three criteria, with precipitating serum antibodies to A. fumigatus or elevated serum Aspergillus IgG by immunoassay. And you have to have radiographic pulmonary opacities consistent with ABPA, or a total eosinophil count more than 500, even if that is historic, meaning before giving steroids to the patient. So once patient fulfills these criteria, you can label as ABPA and treat accordingly. The next allergic manifestation is severe asthma with fungal sensitization, which is a relatively new phenotype for asthma. It is diagnosed by the presence of severe asthma, fungal sensitization, and exclusion for ABPA. So it may present similar to ABPA, but patients usually do not fulfill all the criteria for ABPA. So it may be challenging to distinguish these two entities from one another, and SAFS is usually diagnosed by exclusion. Some experts, they like to think about it as a continuum of fungal sensitization, when you have the asthma on one hand and you have the ABPA on the other end, and the SAFS is kind of like in the middle. The severe asthma with fungal sensitization most likely happens from A. fumigatus, but other fungi could also cause that, although less commonly, like other Aspergilli or Cladosporum or Alternaria. And just like the lung, sinuses also can manifest allergic manifestations for Aspergillus, and these usually patients present with chronic sinusitis requiring multiple courses of antibiotic that with a limited benefit. These patients typically have nasal polyps and congested nasal mucosa and sinuses. The histologic hallmarks of allergic fungal sinusitis is local eosinophilia and breakdown products of eosinophils, or what they call in histology as charcote-laden crystals. And the treatment is by removal of abnormal mucus and polyps with local or systemic glucocorticoids. Some patients in advanced cases, they require more extensive surgery like ethmoidectomy and possibly a local antifungal therapy during the surgery. So we'll switch gears now and start talking about diagnosis of aspergillosis. Histopathologic diagnosis is the gold standard in invasive aspergillosis, where it shows tissue infarction with invasion of blood vessels by many fungal hyphae or acute necrosis with inflammation and hyphae. And hyphae can be seen in cytology or microscopy preparations, like by using the GMS or PAS stains. And fungal culture is important in confirming the diagnosis, given that multiple other fungi can look like Aspergillus. And keep in mind that the bacterial agar, or not the non-selective agars, they are less sensitive than fungal media, so we usually require, it's better to order fungal culture, not just bacterial cultures in general. It's higher yield to obtain for us to obtain the fungus on the fungal cultures, because they use different agars, like the potato flakes agar or the Sabouraud's dextrose agar. Cultures may be falsely positive, like colonization and contamination, or maybe falsely negative, so they need always to be interpreted with caution. Only 10 to 30% of patients with invasive aspergillosis have a positive culture, which is tricky. Bronchial alveolar lavage is usually recommended for diagnosis of invasive pulmonary aspergillosis if there is no contraindication. If peripheral lesions are there, then probably a biopsy would be a better option. As for the galactose non or Aspergillus antigen testing, it relies on the detection of galactose non release from the Aspergillus species during the growth, which is a polysaccharide composed of the galactose and mannose. Antigen testing may be falsely positive with certain beta-lactamase inhibitors like peptazo or coamoxiclav. Serum and BAL galactose are recommended as accurate markers for diagnosis of invasive aspergillosis in high-risk patients like HSCT or hematologic malignancies. It has sensitivity of more than 70% for invasive aspergillosis. It's less sensitive when it comes to Aspergilloma. It's around 38%, or even it's even less sensitive for chronic pulmonary aspergillosis, around only 23%. As for other markers like serum 1,3 beta-D-glucan, and it's recommended for diagnosing invasive aspergillosis in high-risk patients, but it's non-specific because this could be positive in Candida, Fusariosis, BCP, and other fungal infections, as well as with the use of antibiotics like cephalosporins, Amsulbactam, Carbapenems, and so on. In chronic pulmonary aspergillosis, the Aspergillus antibody testing is usually positive, but it's sometimes can be imprecise. The titers fall with successful therapy, so when you think about chronic entities, check for Aspergillus antibodies. As for the molecular testing or PCR, it can be performed on serum, plasma, and whole blood or bronchoalveolar lavage fluid. Diagnostic certainty raises if we have 2 consecutive positive PCR results rather than 1. So sensitivity with 2 positive ones is up to 84% and specificity of 76%. And this PCR, Aspergillus PCR, has been extensively studied in high-risk patients like hematologic malignancies and hematopoietic stem cell transplant recipients, but it's controversial when we use it in other population. So a little bit of notes on diagnostic testing. Remember that positive cultures doesn't always mean disease. Negative cultures do not rule out invasive aspergillosis. The blood cultures are almost never positive in invasive aspergillosis. Serum and BAL galactose, be aware of cross reactions with other filamentous fungi and positivity in setting of colonization. So that also needs to be interpreted carefully. BAL galactose has more than 70% sensitivity even on antifungal therapy, which is a great point. Serum galactose can be used for serial monitoring during therapy in high-risk patients. And here we come to the diagnostic criteria for invasive pulmonary aspergillosis in hematologic malignancy and hematopoietic stem cell transplant recipients. And most of the experts, they extrapolate this to other population as well. So we have the proven IA on invasive aspergillosis if you have a histopathologic diagnosis. That's the gold standard. If you have it, then you have the diagnosis for sure. If you have the right host with someone with neutropenia, LO, HSCT, corticosteroids, immunodeficiency, and you have clinical and radiologic picture with nodular regions, air crescent sign, and cavity, plus you have some microbiologic evidence, whether that is by culture, galactose antigen, 1,3 beta-D-glucan. If you have all of these 3, then you have a probable invasive aspergillosis. And more people are being diagnosed in this category because not on everyone we can get a biopsy. So if you only have the right host and the right clinical and radiologic manifestations and you don't have any microbiologic data, then you have the possible IA, possible invasive aspergillosis, and this is often a driver for empiric therapy. As for treatment, aspergilloma is, if it's simple aspergilloma, usually with no progression over 3 to 6 months, then it just requires follow-up with serial CT scans. Spontaneous resolution may happen in less than 10% of patients. However, there is risk of progression. That's why it's important to follow with serial imaging. Surgical resection is curative, and there's limited role for medical antifungal treatment. And surgical resection is important to manage life-threatening hemoptysis. Embolization sometimes is used to stop the hemoptysis or to stabilize patients prior to surgery. Some experts use perioperative antifungal therapy if there is high risk of spillage of the aspergilloma into the pleural cavity to prevent Aspergillus empyema. But there is otherwise limited benefit for treatment of a simple aspergilloma. As for the Aspergillus nodule, if they were incidentally resected, there is no need for treatment. But patients with nodules that develop these in the context of ABPA or severe asthma may drive improvement of their asthma control with antifungal therapy. Treatment for chronic cavitary or fibrosing pulmonary aspergillosis, it requires antifungal therapy, typically voriconazole or itraconazole. They are the preferred oral agents. Posaconazole being substituted for failure, toxicity, or emergence of resistance. There is now more evidence showing that there is azole resistance on itraconazole, and it's debatable really which one is more tolerated. Is it the vori? Is it the itraconazole? If patients are severely ill, if there is azole resistance or there is azole failure, then you would think about IV therapy with amphotericin B or echinocandins. Treatment for chronic pulmonary aspergillosis is usually for 6 months at least, but if there is progression of disease, impaired pulmonary function test, then long-term or even lifelong therapy with antifungals may be indicated. For the subacute invasive pulmonary aspergillosis, we treat it similar to acute invasive aspergillosis. Drug of choice usually is voriconazole, and if patients have massive hemoptysis, they may need embolization by intervention radiology. Treatment for invasive aspergillosis, keep in mind that early treatment with the right agent is critical. Preferred agent is voriconazole, and for severe disease, we give IV, 6 mg per kg loading dose, Q12 hourly, then 4 mg per kilogram, Q12 hourly as maintenance. For mild to moderate disease, 400 milligram Q12 hourly as loading, and then 200 milligram Q12 with therapeutic drug monitoring and trough targets of 1 to 2. When it comes to the ABPA or allergic bronchopulmonary aspergillosis, corticosteroids are cornerstone of therapy to reduce exaggerated inflammatory response. Itraconazole has a demonstrable corticosteroid sparing effect, and it's thought to reduce the colonization burden. Alternative agents are voriconazole or posaconazole. So general points about the treatment for aspergillosis. When oral antifungal therapy is indicated, use either voriconazole or itraconazole as first-line agents. Posaconazole is an alternative agent in case of toxicity, failure, or resistance. Isovuconazole is a newer triazole and is an alternative. However, there is limited data when it comes to its efficacy and tolerability. And it's also more costly. In severe ill patients or those infected with pan-azole-resistant isolates, IV therapy is indicated. And if there is no resistance, then you can use voriconazole or posaconazole. Otherwise, we have micafungin from the echinocandin group or amphotericin B. For patients with renal failure, creatinine clearance less than 50, and we need to use voriconazole, it's recommended to use the PO rather than the IV formulation, since the IV formulation has cyclodextrin, which could accumulate and causes nephrotoxicity according to what the animal studies have shown us. And the PO voriconazole has bioavailability more than 90%, so it's well absorbed. When you give azole therapies, be aware of drug-drug interactions with azole antifungals. They are substrates for, and they are also inhibitors of cytochrome P450, 2C19, 3A4, and others. And if you want to use itraconazole, put in mind this black box warning that it may cause or exacerbate congestive heart failure. If you have to use amphotericin B, then please use the less nephrotoxic lipid formulation, like liposomal amphotericin B or lipid complex amphotericin B, rather than amphotericin B deoxycholate, because this is more nephrotoxic. Aspergillus prophylaxis in high-risk patients. These are the agents that are recommended for prophylaxis. Posaconazole is recommended and has shown reduced mortality in patients who are high risk with hematologic malignancy or stem cell transplant recipients. Voriconazole and itraconazole are alternatives. IV micafungin sometimes is used if azoles are contraindicated. You usually give 50 to 100 milligrams daily. And other option would be an inhaled amphotericin B, which we don't use commonly. What are the patient population that we give prophylaxis for Aspergillus? So these are the high risk patients, hematologic malignancies with prolonged and profound neutropenia, stem cell transplant recipients prior to neutrophil recovery, GVHD on systemic therapy or high dose steroids, which is more than 1 milligram per kg per day for over 2 weeks. Also, lung transplant recipients are high risk, especially if they are colonized with Aspergillus, if it was a single lung transplant, if there is airway ischemia, or there is CMV infection, or hypogammaglobulinemia, or if there is evidence of rejection requiring anti-T cell therapy. Liver transplant recipients with high-risk features also, because they have 4% risk of invasive aspergillosis, especially those who get a retransplantation or reoperation, patients who are on dialysis or requiring blood transfusions, or patients with pulmonary hepatic failure or prolonged ICU stay. High-risk heart transplant recipients, especially those who are colonized, or if there is risk of, if there is concern for Aspergillus spores in the ICU, those who need the reoperation or they need hemodialysis, they are also high risk. So we give Aspergillus prophylaxis in these patients beforehand because they are really high risk to get invasive aspergillosis. And the last entity I want to touch on before we end our talk today is COVID-19 associated pulmonary aspergillosis. And like the name implies, it's entity related to COVID-19. The more the cases reported, the more we realize that it's there, and it compromises, and it just means that there is more risk of mortality when this happens. So respiratory viruses causes direct damage to the airway epithelium, so enabling Aspergillus to invade tissue. And viral infections in general, they hampers the ciliary clearance and the and they lead to immune dysfunction. A similar entity was previously described with influenza as well. So influenza associated pulmonary aspergillosis. But now with the pandemic, we have much more incidence of this disease. There is excess mortality rate of up to 25% compared to patients without COVID-associated pulmonary aspergillosis. And most reported cases have occurred in patients who are critically ill and or mechanically ventilated with ARDS. Radiographic findings are usually ground glass opacities, consolidation, bronchiectasis, nodules, and cavities. And it's actually maybe challenging to diagnose the CAPA because there's overlap with COVID-19 clinical features. Just keep high suspicion in patients with prolonged or relapsing respiratory failure, structural lung disease, patients who are elderly, more than 65 years of age, or patients who have immunocompromising conditions. And to read more about it, I suggest this paper that was developed by the International Society for Human and Medical Mycology. They defined and gave certain recommendations about diagnosis and management of COVID-19 associated pulmonary aspergillosis. And with that, I'll end my talk and can take any questions out there. Thank you very much for listening. These are my resources.
Thank you so much for a really thorough and excellent talk, Dr. Alnafoosi. And I just wanted to comment, we are seeing more and more cases of COVID-associated pulmonary aspergillosis. And I just wanted to underscore some of your points about that, which is that you should have a high index of suspicion in somebody who has progressive respiratory failure, especially those who have this prolonged presentation for 5 days or more, refractory fever for more than 3 days in spite of appropriate broad spectrum antibiotic therapy with no other etiology. And then some of the radiographic findings that you mentioned, in particular, multiple pulmonary nodules and cavitary disease. So just really wanted to highlight and underscore some of those points that you made, because we are seeing more and more of it.
Yes, that's right.
Yeah. So Dr. Montes, are there any questions? I don't think there are. So Dr. Alnafoosi, again, many thanks for sharing your expertise. Truly fabulous lecture. And again, many thanks to the entire Health for the World team for the opportunity. Thank you all.
Thank you, Dr. Prakash. Thank you, admin.